Are you currently suffering from pain on the front of the knee that's exacerbated with such things as kneeling down or using stairs? Hey everyone, this is Dr. Zach Green here, Performance Sport and Spine, and today's video will be discussing Patellofemoral Pain Syndrome, more commonly known as runner's knee. What does this condition feel like? This pain will often come out of nowhere, and it's poorly defined, most commonly over the front of the knee, the side of the knee, or behind the kneecap. And the pain is aggravated with such activities as squatting down, going downstairs or upstairs, running, or prolonged sitting. This condition is most common in 12 to 19-year-olds and is expected that 25% of people will experience it at some point in their life. And at this point, if you'd please like our video, subscribe to our channel, and then don't forget to turn on notifications. The knee is one of the largest joints in your body, and it's comprised of three bones: the femur or thigh bone, the patella or kneecap, and then the tibia or shin bone. There are two different joints in the knee, the patellofemoral joint and then the tibiofemoral joint. What causes this condition? This is a multifactorial condition, but the main driver is mechanical overuse or overload, where the load placed on the knee is greater than the capacity of the tissues to handle it. The pain is most likely caused by the subchondral bone, but it's likely that other tissues are irritated as well, and there's a whole region that's bothered. It's also important to note that this condition is rarely self-limiting and often requires treatment to resolve it. You also might find with this condition that you hear some cracking or grinding of your knee, and this is called crepitus, and it sounds really sinister, but just know that it's small gas bubbles getting popped from changes in pressure, and it's not your knee wearing out. For diagnosing this condition, it's also important to rule out other things that can bother the knee, and we'll discuss those in more detail later in the video. We're going to go over some posture and activity modifications to be aware of. Since it's an overuse injury, reducing the exercises or activities that are irritating is really important. So decreasing these by 30–50%, especially in acute conditions, is highly recommended, such as reducing your time on running, stairs, or kneeling down. Temporarily avoiding tight-fitting pants or leggings. When using stairs, try to keep your knee more straight, which will help reduce the forces. When standing, again, keep your knee straight and try to minimize bending. And then lastly, avoid wearing high heels. Here are 3 great stretches to help reduce your pain. The first stretch, you're going to roll up a towel or a sweatshirt. It needs to be pretty thick, and you're going to put it in the knee that has pain all the way up, and then you're going to gently but firmly pull your leg towards your buttock, and you're going to feel a good stretch in the quad, and it should feel like it's distracting the knee. You want to hold it for about 20 to 30 seconds or your tolerance, but again, start gently. Don't crank on it. It should be mild tension, and it shouldn't hurt. It should feel relieving, and the pain should decrease. The standing quad stretch, so stretching this muscle right here. So one hand against the wall, and this is the knee that hurts. We're going to grab our shin and pull our leg backwards and pull our foot towards our buttocks, feeling some gentle tension over the front of your leg. Again, you want to not arch your back too much and make sure that the movement's coming from your hip and your knee, not your back. Again, the tension should feel mild and it should feel good. If you're pulling too hard and it hurts a lot, it's not going to help. Work up to holding 30 seconds or to your own tolerance. And the last stretch is the TFL stretch. So this muscle in the front outside of your hip. So if this is the leg that hurts, we're going to cross our other leg over and then push our pelvis out and up at a 45. You can use your opposite arm to help apply some tension, and you should feel some nice stretch on the front outside of that hip. Now, some people are going to find this really helpful, and then others won't find it at all. So try it, and if it's great, use it. If not, focus on things that are more optimal. Again, work to holding up to 30 to 60 seconds. Now we're going to cover the exercise and rehabilitation portion of this video. So there's 4 groups of exercises: quad activation and strengthening, squats, glutes, and then pronation and hip control. We recommend finding one of each group and then progressing independently as your symptoms allow. It's important that our quad, or the front muscle on your leg, activates, and the best way to do that is in a seated position with your knee slightly bent. Place your hand so it's covering the inside and the outside of your quad. And then you want to contract that muscle and feel tension under both sides of your thumb and your fingers. It may help to think about pulling your kneecap up towards your hip, but again, this is an activation or practice exercise, not a strength training. You're not going to feel sore, but you want to make sure that there's tension and you have good motor control of that knee. Seated knee extension. We prefer an ankle weight, but you can also use a PT band around your ankle. So in a seated position, put a light weight around your ankle. With your hand on the quad of the knee that hurts, we're going to fully straighten our leg, contracting our quad, and then return to the starting position. Make sure your torso does not move, and you want to feel that muscle firing under your hand. It may help to think about pulling the kneecap up towards your hip and you want to make sure that you get full extension. So control is important, not just strength. For some people with really irritable knees, they might find that after 45 degrees hurts, so it puts less stress if you go from 90 to 45. So just do that limited range of motion at first, and then over time as your leg gets stronger and your symptoms dissipate, you can work on increasing the range of motion. So standard banded knee extensions. So with a band anchored, you're going to put your leg of your affected knee, and with the knee slightly bent and tension on the band, we're going to put the hand on the quad, and then we're going to pull our knee backwards, getting some tension on that front thigh muscle, and then return. Again, make sure your other leg doesn't move and your torso stays steady, and we're getting tension on that band of the knee, and work on getting full extension. This can be really helpful for people with pain on stairs because we want to get that terminal extension control and strength. Wall squats. So we're going to do some pauses against the wall. So with our feet about a foot away, we're going to squat down to 45 degrees and then hold the tolerance. So mild discomfort's okay, but this should not hurt. If it hurts too much, you can bend your knee less or bring your feet farther out. Level 2, staggered stance. So the leg that's affected, so if my knee pain is on my left side, I'm bringing my left leg closer to the wall, back against the wall, and then again, squat down to 45 and hold the tolerance. Again, some discomfort is okay, but it should not hurt. Level 3, staggered stance with holding a light weight. So again, in that left foot staggered back, holding a light weight, we're going to squat down and then hold the tolerance. Level 4, squats with pause. So we're going to squat down to 45 degrees and then hold the tolerance. Again, some mild discomfort's okay. Keep your weight on your midfoot and you feel tension in your knees and your hips, not your back. Level 5, light weight with pause. So holding a light weight, we're going to squat down to that 45 and then pause to tolerance. Again, weight over your midfoot and tension in your upper back, legs, and hips, not your low back. Level 6, full squat. So keeping your weight on your midfoot, we're going to squat all the way down to your preference and then stand back up. Again, slow and controlled, and feel tension in your legs, not your back. Add additional weight as tolerated. So hip lateral raise. So if my right knee is the pain, we're going to raise our right hip. So putting your hand on your hip, we're going to raise our leg up towards the ceiling and down. And again, you want to feel tension in the glute, not just the TFL. So you don't want to let your leg raise forward. You want to keep it back so you feel most of the tension in that glute. And again, go up and down. For those that have a really tight TFL, this may be hard, so you may want to bend your knee a little bit and make a less challenging exercise initially. But again, it's really important that you feel tension in that back compartment or that gluteal area. Next progression is a side plank. So laying on our side, we're going to raise up and hold the tolerance. I like a pad under my elbow to support it. And again, if that's too challenging, you can start on your knees and then progress to your feet. Level 3, side plank with leg raise. So again, in that side plank position, we're going to stabilize ourselves and then raise our leg up and down. Make sure to keep that tension in the glute and progress accordingly. This is quite challenging, so don't overexert yourself too soon and work up to it. Pronation control and single leg balance. Now, some people are going to find this really helpful and some won't. Again, pronation is a continuum. It's not like you do or you don't. It's how much you do. So really overpronators may find this helpful, but it's not necessary for some people. So before we do these, think of the tripod on your foot. So point A on your big toe, point B by your little toe, and then point C your heel. You want to keep equal pressure on those 3 points like a tripod. Single leg squat. If you have a small step about 3 inches, great. If not, just make sure you're only going down a little bit. And again, keep contact on the stance leg of that tripod. And we're going to touch our heel down and then come back up. If you need to fully rest the heel down, that's fine. But the goal is to not put any weight into that moving leg. Now, 2 common errors is people reaching with their hip. So if you feel a lot of tension here and this is dipping down, you got to not do that. And you got to bend the left knee. The whole point is to restore flexion. So you may have to go gradually, but you got to make sure you're bending that knee and you're feeling some discomfort as the knee bends. To increase the difficulty, you can do the 3-way toe tap. So again, if my right knee is a painful leg, I'm going to bend it as far as I can tolerate, keeping stance on that tripod, tap in front of me as far as I can, to the side, and then behind. And again, a little wobbling is okay, but you want to feel control of that foot and you're not having to shift your weight too much. To increase the difficulty, you can reach farther out or bend your knee more. Some other options are patellar taping can help reduce pain, and then foot orthos can be helpful, but it's recommended only the first 6 weeks and then try to reduce the use over time. How to diagnose this condition. Pain behind the kneecap that's poorly defined, or pain around the kneecap that's also poorly defined. Number 2, retropatellar pain or pain behind the kneecap with activities such as squatting, going up or down stairs, or prolonged sitting. And then lastly, exclusion of all other tibial-femoral conditions. Losing weight is extremely important for this condition for 2 reasons. Since it's an overuse injury, if we weigh less, we're going to put less stress into our bones. It makes sense. So this paper found that of women in their 50s or 60s, the group that was stable weight versus the weight gain group had a reduction of patellofemoral stress of 62%. And number 2, it has to do with metabolic syndrome and low-grade systemic inflammation. So unfortunately, as we gain weight and add adipose tissue, it can increase these inflammatory markers. And these markers have found to play a key role in the disruption of joint health and cartilage degeneration. So maintaining general overall health is extremely important. It turns out our kneecap or patella is actually on different orientation or places on different people, and these different positions can increase people's risk for this condition. The positions can be normal, superior, which is called alta, which is more common than the other one, which is baja or below. Measure requires imaging, so don't let someone use their hands or eyes tell you that you have it, and there's a specific ratio to be aware of, and then unfortunately for some severe conditions, surgery may be required. The kneecap can also be laterally displaced, most likely from dislocations, and this can increase the stress on the patellofemoral joint due to less surface area. If you have this kind of pain, there's a decent chance that you've been told you have chondromalacia patella, but there's 3 reasons why I don't like this condition and giving it to people. Number 1, this cartilage is aneural. It has very few nerve endings and it's very unlikely to cause pain. Number 2, studies have shown that the bone can fail before the cartilage. And then lastly, I think most important, is this term can cause a lot of fear, catastrophizing, and anxiety. If a medical practitioner tells you that you're wearing out your knee cartilage by using it, this will create fear avoidance. So again, this term is probably not very helpful. What are the risk factors for patellofemoral pain? Quad strength deficit, a rapid increase in physical activity, and it seems like with kids, a single sport athlete is more likely than a multiple sport athlete. Surprisingly, to me and maybe to you, things like height and weight, Q angle, which is the angle of your hip coming out of your pelvis, age, and BMI were not found to be risk factors for initial onset of this condition. What are some things that can cause a worse prognosis, and then some psychosocial factors to be aware of? Individuals had a worse prognosis if they had a longer duration of pain, a higher level of baseline pain, or worse function. And then people suffering from anxiety, catastrophizing, or kinesiophobia, which is a fear of movement, were also more likely to have this condition. Lastly, we're going to talk about some other conditions to be aware of that can affect the knee that you need to rule out when dealing with this condition. Patellar tendinopathy. This pain is usually localized to the inferior pole of the patella or kneecap. It gets better as you warm up. There's tenderness with palpation, and the more you load it, the worse it is. Osgood slaughter. This is found in children, and then there's an enlargement of the tibial tubercle, and it should be tender. Isolated fat pad. So this is severe stabby pain, worse with standing with knee extension, usually result from excessive compression. It can be swollen, and ice often helps relieve pain. Patellar dislocation. There's instability, history of dislocation, and there should be passive lateral patellar movement. Meniscus injury. So a history of rotation injury, medial or lateral joint line tenderness of the knee, catching or locking, or giving away of the knee. Thank you so much for watching our video on patellofemoral pain. We hope you found it educational and helpful. If you did, please like our video and subscribe to our channel.